This Week in Virology, the podcast about viruses, the kind that make you sick.
From Microbe TV, this is TWiV, This Week in Virology, episode 859, recorded on January 26, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Ghana, Daniel Griffin.
Hello, everyone.
How long did it take you to get there?
It's about 10 and a half hours once the plane actually took off, but it took a while before the plane took off. And then when you land, I have to say this is pretty neat. I'm going to talk more about it next time on my 100 clinical update. But you get to the airport, you've paid ahead of time. Apparently, they say you're paying for a PCR, but it's an antigen test. And there are all these little booths. So you get sort of put into each little booth, sit down, you get your antigen test, and they use your passport as the identifier. And then you wait. You check on your phone. Oh, your results are ready. You go up, fingers crossed. And only if you're negative do they let you in the country.
I guess you were negative.
Yes. I understand that if you're positive, it's not that they don't let you in, they lock you away in some COVID isolation place. So,
all right. So Daniel, this is update number 99. And I guess for the next one, you'll still be in Ghana, right?
And what I'm going to try to do, what I'm going to plan to do, I hope to succeed, is talk a bit about what I always finish off with, talking about the global situation. So I had the chance already this morning to speak to the dean of the University of Ghana School of Medicine and get some of her thoughts. And I'll be talking to a lot of people as I travel around. So hopefully I'll put all that together, and that'll be our Clinical Update 100 special, a big focus on the global situation.
Sounds great.
All right, but let's get going, Vincent. We've got a lot to cover today.
Okay.
And I will start off with my quotation. I'm going to quote Paul Farmer. If people have not read Mountains Beyond Mountains, I recommend it. Paul Farmer is a bit of a giant in the global health arena. And this quotation: "If access to healthcare is considered a human right, who is considered human enough to have that right?" Now, just starting with our focus, where are things in the U.S. with this quote unquote less virulent, mild variant that's circulating? Things are not good. And I have to say, as I'm learning, the world watches what happens in the U.S. We hit over 3,000 deaths in the U.S. in a single day last week on Thursday, the 20th of January. That was the day we recorded TWiV. Nationally, we are above the Delta wave in average deaths per day in the U.S. Focusing a little bit more on New York, just left there a few days ago. Last winter here in New York, the 7-day moving average peaked at 205. We're already past that, and we're climbing. I will say we are still seeing lower hospitalization and deaths relative to case counts. And I'm going to start with a recent MMWR. Trends in disease severity and healthcare utilization during the early Omicron variant period compared with previous SARS-CoV-2 high transmission periods, United States, December 2020 through January 2022. I would like a better analysis where they really break everyone down, CDC if you're listening, into those groups we've discussed previously. And I'll say, what are those 5 groups? Unvaccinated and no prior infection, unvaccinated with prior infection, and I want to have with time from that prior infection. 3, vaccinated, 2-dose, no prior infection. 4, vaccinated, 2 doses and prior infection. 5, vaccinated with a 3rd booster dose, no infection. And finally, group 6, vaccinated with a 3rd booster dose and prior infection. Because I found this an interesting article, and they do conclude that this apparent decrease in disease severity is likely related to multiple factors, most notably increases in vaccination coverage among eligible persons and the use of vaccine boosters among recommended subgroups. You can see that in the data, but I'd like to have it broken down even a little bit more. Right into children, COVID and mental health. Children certainly are at risk of COVID. We continue to see children get infected, continue to see children hospitalized with COVID-19. When we recorded last week, they haven't updated this yet. We're recording a little bit early. We were approaching 800 deaths. Um, one of the things about being the chief of the ID at ProHealth is I've gotten a lot of opportunities to talk with our pediatricians, with our urgent care physicians, go through cases. I recently had a mom asking about a baby. This is a 5-month-old with COVID. Initially got sick, but then was getting a little better. And then at about day 10, started to poorly again. Fever was back. The vomiting was back. The baby was not breastfeeding well. Babies can have that same pattern, that first week viral phase. Then they move into that second week, that early inflammatory phase. Unfortunately, children can also go on to have long COVID. So this is actually, unfortunately, a pattern we see in some children where they're sick, start to get better, have that second bimodal phase to the illness. And then some of them go on to develop long COVID. And a big topic that always has sort of pulled on me is the neurological aspect of both acute and chronic COVID. And the paper, Prevalence and Risk Factors of Neurologic Manifestation in Hospitalized Children Diagnosed with Acute SARS-CoV-2 or MIS-C, was recently accepted for publication in Pediatric Neurology. Now, in this paper, the authors report on a multi-center cross-sectional study of neurological manifestations in children, so under 18 years of age, hospitalized with a positive SARS-CoV test or a clinical diagnosis of a SARS-CoV-2 related condition between January 2020, April 2021. They're looking here at 1,493 children, 1,278 with acute SARS-CoV-2, 215 with MIS-C. They report that 44% of this cohort had neurological manifestations. And what do they mean by this? While headaches and encephalopathy were the most common, going through, some of these children had strokes, they had cardiac arrest, they had seizures, and they had that really horrible dysautonomia that I've discussed previously, where children just can't even sit up straight without vomiting. So, we do have vaccines. They are incredibly safe in our children. So this is really something that we really need to do a better job at. All right, never miss an opportunity to test. We continue to see this pattern that we've talked about where symptoms now often precede that positive test. I have to say, I'm still waiting for a really good study looking at this. I will say in this section here, the whole flu-rona thing actually maybe had a little silver lining. I've seen some articles where many of us are saying, please don't use that terminology. But people have woken up to the reality that a person can have more than one infection at the same time. And there was a perspective piece, Viral Interference Between Respiratory Viruses, published in Emerging Infectious Diseases. And here the authors discuss the different outcomes, including positive, so additive or synergistic, or negative, so antagonistic interactions. Really interesting discussion of different mechanisms for different outcomes. As clinicians, just really the important lesson here is that a positive test for one thing, let's say it's a positive flu test or a positive RSV, or even if it's a positive COVID test, that does not preclude that there's a secondary process going on. Sort of painful to remember the early days when I think, I will not editorialize, but there was this paradigm where people were only allowed to test for COVID if the flu was negative, if the RSV was negative, if everything was negative, then you can test for COVID. We know very well that a lot of those individuals with flu also had COVID. A lot of individuals with COVID also had other things going on. All right, let's move on. I'm going to spend a little bit of time here, surprise, surprise, on vaccination. Just a bit this week, building on data that boosters do not just improve vaccine efficacy against infection, but also that a booster improves vaccine efficacy against disease. We're seeing data here, but when you look at our experience, when you even look at it compiled for the large healthcare systems, the majority of the individuals ending up hospitalized are unvaccinated. There are some people that have only gotten 2 shots, end up in the hospital. There are very few individuals that have gotten 3 shots that end up in the hospital. So um, there was some nice, I'll say, infographics from the CDC demonstrating the impact. And here they say in December, compared to fully vaccinated persons in each group that we're going to go through here, the monthly rate of COVID-19 associated vaccinations were 16 times higher in unvaccinated adults aged 18 years of older, 9 times higher in the unvaccinated adolescents, 12 times higher in unvaccinated adults 18 to 49, 17 times higher in unvaccinated adults 50 and up. You can even break that down 50 to 64, 65 and up, 17 times higher. But then here's the comment on vaccine efficacy of boosters. And here we have in December, compared to fully vaccinated persons with additional or booster doses in each age group shown below, I'm going to go through this, the monthly rates of COVID-19 associated hospitalizations were 44 times higher in unvaccinated adults, 49 times higher in unvaccinated adults, 65 years and older. But let's go on to another MMWR release. Effectiveness of a third dose of mRNA vaccines against COVID-19 associated emergency department and urgent care encounters and hospitalization among adults during periods of Delta and Omicron variant predominance. Vision Network 10 states August 2021 through January 2022. Now, I want to break this down to really look at the comparative efficacy after 2 doses versus after that third dose or booster. And I am looking forward to the John Muscola episode where I know this will get discussed in depth. So I'll even next time tell people to watch that. So let us start with vaccine efficacy against laboratory confirmed COVID-19 associated emergency department or urgent care encounters, right? So that's disease severe enough that you're seeking medical attention. Now, the authors reported that during the time of Delta, the vaccine efficacy against COVID-19 associated ED and UC, so emergency department and urgent care encounters, after 2 doses of an mRNA vaccine was initially 86% for the first months, and then it dropped to 76% at 6 months. With a third dose or booster, this rose to 94. When Omicron became dominant, the vaccine efficacy against ending up going to the ED or urgent care after 2 doses initially was down at 52%. After 6 months, this dropped to 38%. With a third dose, this rose to 82%. So showing that Omicron versus Delta with or without that third dose. What about vaccine efficacy against hospitalizations, right? That's in many ways, we've talked about that as being this severe disease. Now, during the period of the Delta variant, the vaccine efficacy against COVID-19 associated hospitalization was initially 90% for the first 6 months, dropped a little to 81% once we got out after 6 months after dose 2. Then with a boost, we get this back up to 94% for some period of time. During Omicron variant predominance, the vaccine efficacy for the first 6 months was down at 81. After 6 months, it drops to 57, but then we boost back up to 90% after dose 3. So just getting data now, which I find quite compelling, that not only does the boost for some period of time improve the vaccine efficacy against infection, we may actually, well, I think this data supports, we are getting improved vaccine efficacy against severe disease. Now, SARS.
Daniel.
Go for it, Vincent.
All right. So 2 things.
Yes.
First, John Mascola said one of the problems with this hospitalization is that about half of the people who are supposedly hospitalized for COVID actually are hospitalized for something else. So they get a COVID positive test, but then they're there for some other reason. And he's not clear that that gets pulled out of this data. So these data may not
Yeah.
be so dependable. Second, wait a minute now. People are saying Omicron is milder. So how can vaccine efficacy against severe disease be going down? I don't get that.
Interesting, right?
Well, I think the key is it's not really milder, right, in people. So,
Yeah. No, I mean, and it is really tough. I mean, we've got to, people have to stop saying this about, oh, it's milder. We are now sitting, when the rubber meets the road, we're sitting here in the US with over 3,000 deaths on days. We're seeing the average over 2,000. We're seeing the average number of people dying per day in the US right now with Omicron higher than it ever was with Delta. I have a lot of trouble buying this. People are ending up with COVID pneumonia. They're ending up in the ICU. They're dying. The word mild just some statistician might in the future at some point tell us that in certain contexts it's milder. But what we're really seeing is, I think, vaccine efficacy. And I think John makes some good points. A lot of times people end up in the hospital. They're put in that room. They have a COVID diagnosis. They're not even on oxygen. I'm not sure that in the early days we would have admitted these people or even kept them in the hospital as long as we do. So I think that that's a good point John makes. All right, another nice paper. This is SARS-CoV-2 vaccination induces immunological T-cell memory, able to cross-recognize variants from Alpha to Omicron. And this was accepted for publication in Cell. This is really a beautiful paper. And worth taking the time to go through and look at the paper, look at the figures. I love getting to see the actual flow cytometry plots with the different T cell subsets being gated on for activation markers. They actually have a very nice graphical abstract that really hits the high points of the paper. And it really goes through, I think you could pretty much look at start with the graphical abstract, see that they're looking at a number of different SARS-CoV-2 variants. They're looking at the impacts of vaccination over time. They're looking at B cells, but they're also looking at T cells. And we do see some preservation of the receptor binding domain B cell reactivity at 6 months post-vaccination. We see average being about 71%, with Omicron dropping to about 42%. But if you look at the T cell data is really impressive. There's really good T cell reactivity at 6 months post-vaccination. Average about 90%. Even with Omicron for CD4, it goes to 84. The CD8s average 87, going to 85. Not really much of a difference there. So really, I have to say, encouraging when it comes to looking at the durability of the T cell responses. Vincent, I think recently you tried to, with one of your guests, say that, is it true that T cells will save us all? And I know there was
yes.
pushback.
Well, it's funny because I think this is one of Alessandro Sette's papers, right?
Yes, this is out of Scripps. Yeah, so Alessandro and Shane and the whole gang.
So he certainly talked about this. But for some reason, so I said, are T cells going to save us? And he said, well, it's a little more nuanced than that. But I think I got it from him originally, Daniel.
Yeah. Like a true immunologist. It's very complicated, Vincent.
Well, yes, that's what they all like to say. It's very complicated. It's very, well, really, let me know.
There's a lot of stuff going on. You would never understand.
I understand that there are more to immunology than antibodies and T cells, right?
But there is. The nice thing I have to say, this is, we started off, no one cared about anything but their antibodies. I want to know about my antibody. I want to hear about anything else. And now at least people, I think, are starting to be interested in T cells. And then hopefully this will evolve. We'll start talking about dendritic cells and B1 cells and natural killer cells and all the rest.
When do you think we'll talk about FC receptors?
Oh, non-neutralizing FC mediated.
Yeah,
that's really complicated, Vincent.
Okay. All right.
All right. Well, what I will say is sort of a news brief. Pfizer and partner BioNTech have begun testing the Omicron variant-specific vaccine. And they're doing this in 3 groups, right? So folks who are completely unvaccinated. So there's still people out there who are completely unvaccinated, but willing to enroll in a trial of a vaccine. So that's cool. Vaccinated with 2 shots, and then they're going to get this, or they've already been boosted. They've already got that 3rd shot, and they're going to get this as their 4th shot. So that'll be interesting. We don't know. Is this going to be better? Do we need this? Where does this fit in? So this will be interesting data that I'll be curious to see.
So, Daniel, if
Passive
in 2 months we
vaccination.
have another variant, what are we going to do?
That's always the problem, right? With science, it's like you don't have the answer until you're a dollar late or a day late, dollar short. I think that's the issue. Do we keep chasing variants? Are we quick enough to chase the variants? This is something I think that a lot of us would have been interested in knowing before Omicron became 99% of the sequences.
Seems
So yeah,
to
will
me we
Oh,
just
Vincent?
vaccinate everyone and we don't have this problem, right?
That's the biggest point. And I think if you asked from I always say this most selfish thing we could have done in the developed, wealthier nations was vaccinate the world. Because what do you want? Do you want what, 4th shots, or do you want no new variants? And the way to stop the variants is to help the world all get vaccinated. All right. Passive vaccination, we are starting to use Evusheld, right? This is the AstraZeneca product, long-acting, 6 months, where a person who's not able to make those antibodies themselves can be given them passively. We don't have enough. There's only 300,000 doses or so for the whole country, much less the world. All right, here's where we have a lot going on. The period of detectable viral replication, the viral symptom phase. This is the time I said for monitoring. I say for monoclonals, but those are in short supply. We'll get to antivirals, enrollment in clinical trials. Not the time for steroids or doxycycline or azithromycin or zinc or aspirin or other unproven or potentially harmful potions. This was an interesting update. The FDA revised the authorizations for 2 of the monoclonal antibody treatments. So the bamlanivimab, atezolizumab, right? That's the Eli Lilly cocktail. The casirivimab, imdevimab, that's the Regeneron, the RegenCov cocktail, to limit their use to only when the patient is likely to have been infected with or exposed to a variant that is susceptible to these treatments. That seems kind of obvious to me, right? Let's not use these if we don't think they're going to work. They then go on to clearly state, and it actually took this. Data show these treatments are highly unlikely to be active against the Omicron variant, which is circulating at a very high frequency throughout the United States. These treatments are not authorized for use in any U.S. states, territories, and jurisdictions at this time. It's painful that the FDA had to state the obvious and say, let's stop using something that is not effective. 99% is Omicron, 99% these are ineffective. We do have some effective therapies, and they are recommended in order of efficacy. Number 1, right, Paxlovid. Number 2, sotrovimab. That's our monoclonal that still works. Remdesivir, but remember, and we're going to go a little more into this, that is the 3-day outpatient IV, and molnupiravir. Now, previously, as we talked about with remdesivir, there was this odd situation where the FDA, the NIH was recommending the off-label use of remdesivir. Well, now we have an update from the FDA, and in a press release from the FDA, we heard that the FDA has expanded the approved indication for Veklury, that's remdesivir, to include its use in patients who are not hospitalized, have mild to moderate COVID-19, are at high risk for progression to severe COVID-19, including hospitalization and death. In this is also the other change is the EUA has been updated to authorize the drug for treatment of pediatric patients weighing down to 3.5 kilograms, right? Before we had this 40 kilogram cutoff. Now you can go down to 3.5 kilograms. You go down to pediatric patients less than 12 years of age. So Remember, this is the new indication. This is that 200 milligrams the first day, and then 100 milligrams on day 2 and 100 milligrams on day 3. This is, in the 80s, almost 90% reduction in progression to ending up in hospital. I always feel like I have to throw a reminder here. If people are being treated with those Medrol dose packs of steroids and antibiotics during that first week, this is specifically discouraged. This is not helpful. There's data showing this is harmful. If a provider is still excited about ivermectin, fluvoxamine, metformin, or some other therapeutic, enroll these folks in a clinical trial. All right, let's move on to the early inflammatory phase. Remember, this is the time we start thinking about immune modulation when people often end up in the hospital. As we're seeing now, there's an overlap here with remdesivir, but most of us are not using remdesivir if it's been more than 10 days since symptom onset. So really sort of the whole concept, which I'm glad that people are focused on treating the viral phase with antivirals and then thinking about immune modulation when we go into that early inflammatory phase. All right, an update on anticoagulations at time of discharge from hospital. So the individual has made it through that hospitalization. It's time to go home. Are we going to give them a whole bunch of blood thinners, anticoagulants? Well, we have a new update from the American Society of Hematology. So the American Society of Hematology guideline panel suggests that outpatient anticoagulant thromboprophylaxis not be used for patients with COVID-19 who are being discharged from the hospital and do not have suspected or confirmed venous thromboembolism, VTE, or another indication for anticoagulation. Conditional recommendation based on very low certainty in the evidence about effects. And then this is qualified. I'm on this panel, so I'm kind of guy who likes to qualify things. The panel acknowledged that post-discharge thromboprophylaxis may be reasonable for patient judged to be at high risk of thrombosis and low risk of bleeding. They have a really nice infographic, but it's really straightforward. Don't discharge them on anticoagulants unless they are at high risk, unless there's a specific indication. Unfortunately, I have to say, some of the healthcare systems, this is the guideline. Everyone's being sent out on $600 worth of anticoagulation, which is not recommended currently. All right. No one is safe until everyone is safe. As some of our listeners might know, I mentioned this early on, I'm currently in Ghana in West Africa. Next week will be our 100th clinical update. So anticipate that being sort of a special global focused episode. I did want to actually talk about the WHO's executive board is meeting in Geneva this week to set the agenda for the World Health Assembly in May. And during the address to this group by the WHO Director General Tedros Adhanom Ghebreyesus, basically saying it's dangerous to assume that Omicron will be the last variant or that the world has reached the end game of the pandemic. He warned that conditions are ripe for more COVID variants. I think we've talked repeatedly. The way to combat this is more vaccine equity. All right, so I'm going to finish on that note, but remind everyone this is going to be about our last episode in January. During the last few days of this month, donations to PWB will be increased and given to support Microbe TV. Thank you so much. Everybody's been great. So I think we're going to be able to be much more supportive than we initially had hoped. But you can also go right to Microbe TV, which is now a 501c3, or go to parasiteswithoutborders.com, click on that donate button, and help us continue to do all this great work. Thank you.
We also have an internship available, and if you're interested, you could check out the description at parasiteswithoutborders.com. And if you want to send in an application, daniel@microbe.tv. Time for some questions for Daniel. You can send yours to daniel@microbe.tv. So we have one from Kip and Laura, who are two PharmDs in San Francisco. They have a real Lulu of a case and wish to know if you've heard of this possible adverse reaction. 57-year-old endodontist, June 2020, uncomplicated COVID, 3 doses of Pfizer, 6.5 days after dose 3, started acting whacked out in his office, thought he was having a stroke, severe auditory and visual hallucinations, rushed to the ED, systolic blood pressure over 200, tox negative, MRI non contributory, further workup, inflammation of the lining of the brain, terrible hallucinations, continued 2 days after admission, received first IV steroids within hours, symptoms resolved 95%, one more dose IV steroid discharged within a week. I see there are scattered case reports of acute encephalopathy following mRNA vaccine. It appears this adverse reaction is rare. I'm interested to hear what you have heard. We don't want to add more fears to an already vaccine hesitant culture, but if this problem is happening, clinicians should be made aware so that prompt therapy can be initiated. Please let know how valuable you and the TWiV team are to so many.
Yeah, so as you mentioned, there are a few rare case reports, and actually, I sort of as I was listening to this, I was thinking, okay, you're going to try steroids, etc. That in these rare scenarios has been how it's been approached. The thought, and it's hard to confirm this at this point, is maybe this is some sort of off-target antibody response. Um, yeah, I think that this may be one of those rare, but again, we're talking about, 1 in a million type incidents. The big challenge now is going to be, what do you do going forward? If this is an off-target antibody response to seeing spike, what if this person goes ahead and actually gets infected with SARS-CoV-2, develops acute COVID? Would that trigger this? What are going to be the challenges going forward with vaccination? Is this an individual that might be a candidate for something like Evusheld? So yeah, certainly individuals like this, you want to get involved. You want to talk to an allergy immunologist. You want to talk to an infectious disease specialist that has seen cases like this to sort of help you move forward.
Beth, who is fully vaccinated and boosted, writes, our question has to do with corticosteroids such as inhaled asthma medicines, beclomethasone, dipropionate, and also nasal allergy sprays like fluticasone. If a patient takes these drugs regularly, should they stop taking them if they get COVID? I believe you have said steroids are contraindicated during the first week of an infection. I also seem to recall there were early reports in 2020 that drugs like fluticasone may prevent serious disease. Can you clarify?
Yeah, so this is a great question for updating our perspectives. Early on, we really didn't know. The early reports out of China, I think, really scared us. Don't use steroids. There actually are some ongoing studies now using inhaled corticosteroids. Is there some potential benefit in the localized area? Early on, we were telling people not even to use those nasal steroids because we were concerned. At this point, we've come to where if someone has allergies, if someone wants to use those nasal steroids, this is something we're comfortable recommending they continue. They don't have to stop. It's the oral, it's the parenteral, it's the higher dose steroids that we worry about. And the inhaled steroids, like the fluticasone you talk about, there's a budesonide inhaled steroid trial ongoing. There's actually several ongoing. So if that's what it takes to keep a person out of the hospital, to keep their asthma under control, it's reasonable to continue. We're a lot more comfortable with these therapies than we were early on as we've learned more.
Deborah writes, I work in an outpatient COVID clinic. One of the issues that remains unclear is care for patients that are newly infected and require oxygen but not hospitalization. I understand that they do not qualify for monoclonal antibodies. I know typically steroids are not recommended if patients are not on oxygen, but there are data to prescribe steroids in patient if an oxygen but questionable outpatient. Will you please go through the data and recommendations, specifically the timing? Is it best to wait 10 days in order to not potentially prolong shedding? I also suspect that many of these patients should probably be hospitalized, but haven't been due to lack of local resources.
Yeah, so this is great, and this is a little more challenging with the change in kinetics that we've seen with Omicron. So initially, what we saw, it was really nice, right? You had, you know, 7 days would go by, and then your, I guess your seniors, people with the most comorbidities, you'd start seeing them at about day 8 start to become hypoxic. The oxygen would drop. Some of our younger individuals with less comorbidities, they wouldn't start to have their oxygen levels drop until about day 13, so sort of the end. Unfortunately, now we're seeing this situation with Omicron where it's day 6. And the person is already with an oxygen saturation below 94. Maybe it's 91, maybe it's 90. So this is tough, right? Because now we're looking at data from the other variants. We're looking at a real separation. The viral kinetics, I'm going to say the RNA copy numbers are on their way down. We're thinking the viral replication is shutting down. Now you're starting to get this early inflammatory phase, almost two separate. So reasonable to start those steroids as we got into that second week. It is a little bit trickier now, right? Because we have data showing that if you start those steroids too soon, people do really poorly, right? It was a 6-fold increase in progression. So we do want to hold off. I personally would hold off till about day 7 would be the earliest I would think about starting those steroids. It's a little tricky, right? The WHO has, I think, really weighed in on the most important but least reliable bit of data is history, right? So someone says, oh, I've only been sick for 3 days. They're already hypoxic, probably getting to about day 7 by then. So we certainly have individuals where they're out of the hospital. It's about day 7. They're started on steroids. We're starting them on the home oxygen therapy, and then trying to keep those folks out of hospital.
Our last email is from Mario, who is a family medicine doc in Los Angeles, and says your videos are informative for his practice. I have a 15-year-old daughter, vaccinated, not boosted, contracted mild COVID on December, recovered now. Are there any data that we can look at to say a booster is or is not advantageous for a previously vaccinated teen with 2 Comirnaty doses after recently getting COVID? Presumably, she has protective antibodies against Omicron, right? And probably developing cell-mediated immunity. So she wouldn't need the extra antibody boost that the vaccine would give to her, or would she benefit from the extra antibodies and the cell-mediated immunity from the vaccine?
Yeah, this is a great question. And we don't completely know, right? That we don't have the data as granular as I would like. But here's sort of my thought on this. When someone ends up getting infected with SARS-CoV-2, so they get a case of COVID-19, we don't really know the dose relative to what their immune system is seeing. And I think this would be if your child had 2 doses and then they went and they saw the doctor said, oh yeah, I gave them a little bit of vaccine. And you're like, well, did you give them the full dose? I don't know. Maybe I gave them a little. I'm not really sure. I didn't look. I just drew. I was looking the other direction. And so you don't know if they've gotten that 3rd dose. So in our recommendations, we don't necessarily count that infection in our recommendations about vaccines or about boosting. The other part of your question, which is I think the important question, is how old is your child? How important is a booster in an individual in younger age group? At this point, as you're well aware, it's boosters for all. I think the younger an individual are, the less benefit we get from continued boosting.
That's COVID-19 Clinical Update number 99 with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.